First thing, let us come to a broad classification of how these inherited disorders of sodium handling are classified. Okay, the first group are the patients with hypokalemic alkalosis. So what does that mean? If the potassium has to be low and H plus has to be low, what did I tell? Did you remember that aldosterone has to be excess, right? The aldosterone activity is excess. That is why this is happening. So aldosterone activity can be excess because of two things. Either it can be secondarily stimulated or it can be primarily stimulated. Okay. So aldosterone, I would repeat here, potassium or H plus is low. That means the aldosterone activity is excess. That is, it is leading to increased activation of ENaC, pushing the sodium inside, and it is going to send the potassium and H plus outside to maintain electroneutrality. So that is why there is hyperkalemia and there is metabolic alkalosis. Now it can be because of increased aldosterone enzyme, or it can be because of aldosterone or mineralocorticoid receptor activation, or it can be because of ENaC activation by itself without even involving aldosterone. Okay, so aldosterone can be increased primarily or aldosterone can be increased secondarily. Okay, now let's look into this classification. The first thing is there is sodium wasting and normal blood pressure, Bartter and Gitelman syndrome. Okay, I'll let you know what happens in these two situations. In Bartter and Gitelman syndrome, sodium potassium 2 chloride channel, and this is in Bartter syndrome, and sodium chloride channel. This is the Gitelman syndrome, right? So these two are blocked. So what is going to happen? More of sodium is going to reach the collecting duct. So once the more sodium reaches, the aldosterone gets activated secondarily. Okay, here secondary activation of aldosterone happens. Once this happens, increased sodium gets reabsorbed and leading to excretion of K plus and H plus. But how much ever it increases, it cannot reabsorb sodium to a very high level. So there will be some amount of sodium wasting along with potassium and H plus. So these patients will have low blood pressure and sodium wasting. Right? So this is the first section where who have normal blood pressure or low blood pressure. Second one is hypertension. This is true or apparent mineralocorticoid excess. So there is activation of the ENaC channel, which is Liddle syndrome. Okay, or there is syndrome of apparent mineralocorticoid excess, in which cortisol has a function like aldosterone. So we can assume that aldosterone levels are increased. Similarly, glucocorticoid remediable hyperaldosteronism. Okay, in this condition also aldosterone levels are high because ACTH stimulates the what happens in glucocorticoid remediable aldosteronism. The ACTH stimulates the aldosterone secretion. Okay, that is why by giving glucocorticoid we can remedy the situation. So in this situation also there is increased activation of aldosterone. Okay. And there are adrenal enzymatic disorders, some sort of congenital adrenal deficiency, congenital adrenal hyperplasia, which causes this condition. Okay, so these are the situations in which patient will have hypokalemia and alkalosis. Hyponatremia, hyperkalemia and acidosis. So that means what? There is a opposite of this function, that is patient is gaining excess potassium and H plus because the mineralocorticoid function is not there. So low sodium plus increased potassium and increased H plus means there is low activity of aldosterone. Okay, so this can be pseudo reduction, pseudo hypoaldosteronism. Like I told, there could be a inactivating mutation of the mineralocorticoid channel or the ENaC channel, or this can be true. Okay, true aldosterone synthase deficiency. Okay, and if in this condition there is hypertension, then there is a condition called Gordon syndrome, There is Gordon syndrome, which leads to activation of the sodium chloride channel in the distal tubule and also inhibition of the ROMK channel. So, this leads to hyperkalemia and the acidosis. So, this is a condition where there can be hyponatremia, hyperkalemia and acidosis. Okay. Now, once the patient comes with hypokalemic alkalosis, the patient has to undergo clinical examination to see the volume status, blood pressure, biochemistry including sodium, potassium, chloride, bicarbonate and calcium, magnesium, phosphorus, albumin, urea, creatinine, osmolality. All these are the routine tests. Okay. Now, in the urine also sodium, potassium, chloride, magnesium, calcium, creatinine, osmolality. This is to see which ions are getting excreted in the urine and which are deficient in the blood. Now, if there is hypertension, hypervolemia, evidence of salt retention, that means what? There is excess activity of aldosteronism. Okay. So, if it is renin aldosterone is elevated, then it could be Conn syndrome, that is primary hyperaldosteronism. If renin aldosterone are suppressed, that means the channel, the effector channel is activated, so the hormone is suppressed, right? So, the effector channel gets activated in the Liddle syndrome, in apparent mineralocorticoid excess or same, and also glucocorticoid remediable aldosteronism. Similarly, if it is low normal blood pressure, euvolemia or hypovolemia, and there is evidence of salt wasting. In this situation, we have to see the fractional excretion of chloride. If the fractional excretion of chloride is more than 0.5, then this is because of renal salt loss. If the fractional excretion of chloride is less than 0.5, then it is extra renal cause. Look for sweat or look for enteric loss. Okay, so this is our interest, that the patient is presenting with low normal BP with hypovolemia and salt wasting. Now, once the chloride is lost more, if it is only hypercalciuria that the patient is having, then we will think about Bartter syndrome. If patient is having hypocalciuria and hypomagnesemia, then we will consider it is Gitelman syndrome. Okay. So, this is how we differentiate between these two conditions. I'll explain later as to why this happens. And once that is diagnosed, the treatment is salt supplementation and COX inhibition. In the Gitelman syndrome also, it is salt supplementation. Okay. So, that is if the patient presents with hypokalemic alkalosis. What if the patient presents with hyperkalemic acidosis? The initial examination, clinical, blood and urine will be the same. If the patient has hypertension and there is evidence of salt retention, so what does this mean? That there is activation of the aldosterone axis, right? So, renin, if renin is suppressed, aldosterone is variable, then think about pseudo hyperaldosteronism 2 or Gordon syndrome, which was because of activation of the sodium chloride channel. So, the treatment will become thiazide. Okay. So, here the difference is that patient will have hyperkalemia because of inhibition of ROMK channel, okay, and also acidosis. Now, if the patient's BP is low or normal, means there is a chance that aldosterone is not acting. So, there are two possibilities. One is the aldosterone is increased but the receptor is not functional, okay. So, that becomes pseudo hypoaldosteronism type 1. Or it might be that aldosterone itself is deficient. So, this could be like aldosterone synthase deficiency, and in this situation mineralocorticoid supplementation has to be done.